Hello, future doctors. How are you all? Welcome back to MedSteps YouTube channel. So, I am Dr. Anand Jana. So, right now we are doing general surgery series. So, I already covered abdominal trauma part 1. So, we covered the foundation of abdominal trauma, including the anatomy, physiology, and mechanism of injury, and types of mechanism of injury, and pathophysiology, clinical presentation, and primary survey, and fast examination, and the initial assessment of trauma patient. So now it's time to move into the most critical and exciting part of trauma injury and surgery. So management and operative decision making. So before going to video, let me ask you a question. A 25 years old patient arrives after a road traffic accident. His blood pressure is 80 by 50 mmHg and pulse rate is 140 beats per minute and the fast scan is positive. What should you do next? Should you send him for a CT scan? Should you observe him? Or should you take him immediately to the operating room? So these are the life and death decisions trauma surgeons make every day. So in today's section, we will learn how to manage hemodynamically stable versus unstable patient and the non-operative management and indications of emergency laparotomy and how to do damage control and resuscitation and damage control surgery and massive transfusion protocols and splenic injury management, liver trauma management and hollow viscous injuries management and how to do ICU management and complications and what are the in INI-CET settings, what are the questions the doctor might be can ask. So these are the things we are going to cover mostly high yield exam PLs. So by the end of this lecture, you will able to confidently approach abdominal trauma like a surgical resident and understand the principles used by trauma surgeons worldwide. So grab your notebook, think like a trauma surgeon medical student, and let's begin our part 2 of our abdominal trauma general surgery series masterclass. So the most important rule in trauma surgery is simple. Unstable patient goes to the operating room, stable patient goes to the CT scan. So let's start with the management overview of abdominal trauma. So here you can see one blunt trauma evaluation. So whenever patient coming to accidental emergency department, the fundamental principle is the most important question in abdominal trauma is the patient hemodynamically stable or unstable. So is everything else comes after this. So first of all in trauma management, if patient like hemodynamically stable, okay, then if patient hemodynamically stable, then we have to check that blood pressure, the normal blood pressure and responding to fluids, then we have to send that patient for CT scan. Okay, then we have to do selective management. So if patient like hemodynamically stable, you can go with fast scan. Then after if it's positive, then you have to go with CT scan. If the patient like negative, then you have to just observation. Okay, so these are the things. Next one, if patient like hemodynamically unstable, the blood pressure is falling down and patient in shock, the fast scan is DPL and positive, then you have to go with immediate laparotomy or immediate surgery like laparotomy. In negative, search for other source of hemorrhage. Okay, so these are things. The main goals for doing this, for checking this hemodynamically stable and unstable, for saving life, for stop bleeding and for control the contamination and for preserving organs and for prevent multiple organ damage. Okay, so these are the things. Now in conservative management, if you're seeing here, one of the biggest advanced in modern trauma surgery, that is non-operative management. If you're doing CT scan, here you can see it's normal, so consider discharge. If patient have injuries, if it's like major and non-operative, just observe in ICU observation. If it's minor, we don't need to do any operation, just hospital observation is very important. If operative case, we have to do laparotomy. So in non-operative management, the indication will be like the patient must be stable and no peritonitis and no hollow viscous injury. So most commonly used for splenic injury and liver injury and renal injury based on grade. If it's like grade 1, grade 2, we will discuss this thing when we are going the organ structures. Okay, injury, that time we will discuss about the grades. Next we can see contraindications. When we don't need to do this non-operative management, if patient like hemodynamically unstable and patient have peritonitis and evisceration and perforation and ongoing hemorrhage, and we have to monitor the protocol like ICU or high density unit, and we serial vitals we have to check, and we have to check hemoglobin every 4 to 6 hours, and we have to repeat abdominal examination, and we have to repeat imaging if necessary. So we can see some components we have to do like bed rest and intravenous fluids, and we can do blood transfusion, and we can do analgesics like painkiller, and we have to do always serial focused assessment sonographic in trauma. Okay, so the stable patient with a grade 3 splenic injury often does not need surgery. Okay, so grade 1, grade 2 or often grade 3 based on the patient that assessment. While doing assessment, if patient like is unstable, you don't need to do any surgical management. Okay, so that's why conservative management is very important. So if you're seeing here, now we are going to discuss about surgical management of abdominal trauma. So surgical management, we can see the absolute indications for laparotomy. We can see here the patient must be hemodynamically unstable, and patient must be like peritonitis. If patient have any evisceration and free air under diaphragm, okay, and hollow viscous perforation, and the positive fast with shock, then what we have to do? We have to prepare for advanced traumatic life support, resuscitation, and blood products we have to keep ready, and we have to start broad spectrum antibiotics, and we have to insert urinary catheter for checking that volume output. Then after nasogastric tube, and we have to give proper position for the patient like supine and arm extended, and anesthesia like general anesthesia, rapid sequence induction, and we have to keep sterile instruments like major laparotomy set and vascular clamps and section devices and staplers and packing pads. So if preferred incision, we have to do midline laparotomy. If you're doing midline laparotomy, we have to do from G5 to pubis. We have to do preferred midline incision. This is advantage is the fast and excellent exposure and extendable. So easily we can do surgery will be like fast. Okay. Next we have some types of surgeries. So that operative procedures will be like first one, damage control laparotomy. This damage control laparotomy is most important trauma surgery concept. Why? For damage control, the patient develops lethal triad. Lethal triad means what? If mostly we can see lethal triad means the patient will go to hypothermia. Okay, the patient will go to acidosis, and the patient will go to coagulopathy. Then after these three things will lead to patient death. So this is lethal triad. So that's why we have to damage control for becoming hypothermia, acidosis, and coagulopathy and death. Instead of definitive surgery, we have to control damage first. So in phase 1, first we will do emergency surgery. We can find objectives like for stop bleed. We have to stop the bleeding. Then we have to control the contamination, and we have to close temporarily. Then after phase 2, we have to keep monitor the patient in ICU resuscitation. Then after we have to correct the hypothermia and acidosis and coagulopathy with medications, that lethal triad. Then after in phase 3, we have to take that patient to return to operation theater, and we have to do definitive repair. Okay. So these are the things. Next we can see emergency exploratory laparotomy. In emergency exploratory laparotomy, you can see step 1 will be like midline incision. In step 2, we have to enter abdomen, and we know the purpose to rapid access. The step 3, we have to evacuate blood, and we have to section hemiperitoneum. In step 4, we have to go check that 4 quadrant packing, like right upper quadrant and left upper quadrant pelvis and para and paracolic gutters. The purpose temporary hemorrhage controlling. Okay, next we can see step 5, like identify the source, like which organ become injury, like liver, spleen, bowel, mesentery, we have to find out. Then we have to do definitive control, and we have to repair, and we have to do resection, and we have to do, if like spleen damage, then we have to do splenectomy, and we have to pack. Okay, so these are the things. So definitive repair later when patient stable. So based on organ specific intervention we have to do, like splenectomy means we have to take out. Splenotrophy means just we have to with suture, or we have to do management. Okay, then after hepatorrhaphy, and another thing we have another thing we called hepatic resection. Next, bowel repair means we have to do bowel repair, and we have to do resection with anastomosis and stoma. So next, first of all, we can see that organ most common primary most common injured organ, that is spleen. So we have AAST, that means American Association Surgery for the Surgery Trauma Injury Scale. We have total 4 different scales, 5 different gradings. So based on that spleen injury, first of all we can see grade 1. We can see grade 1. In grade 1 we can see like a capsular tear less than 1 centimeters. So that is spleen grade 1 injury. Okay. Next we can see grade 2. In grade 2 you can see like parenchymal lacerations like 1 to 3 centimeters. Okay. So if like 1 and 1 to 3 means we don't need to do any surgery, non-operative management we can do. Okay, so next we can see that is grade 3. In grade 3 we can see like totally the lacerations more than 3 centimeters. Okay, you can see these 2 pictures. This is the grade 3. Next we can see here that is grade 4. In grade 4 we can see active bleeding, and in grade 5 that is like totally hilar injury and shattered spleen injury. So this is grade 4 and 5. The patient is unstable. Then we have to do splenectomy. So indications of splenectomy, mostly if patient like patient getting like uncontrolled bleeding, grade 4 and grade 5 injury, and shattered spleen, and failed non-operative management. In some cases failed non-operative management in grade 3, we have to do splenectomy. So steps of splenectomy means, first of all we have to do mobilize spleen. Then after we have to divide splenocolic ligament, and we have to like splenorenal ligament and splenophrenic ligament. Then after we have to control the hilum, and we have to ligate the splenic artery like this, and splenic vein. Then after we have to remove that we have to inspect tail of pancreas carefully. Then after we have to remove spleen. So structure at risk while doing splenic surgery, that is tail of pancreas, because this is the most common asked setting question. So while doing splenic surgery, which organ can become damaged? The structure means tail of pancreas. Okay. So next we can see here that is liver. Liver is the second most common injury. So in minor surgeries, just we have to observation. In moderate injury, we have to do packing, and we can use some hemostatic agents. Okay. Next, in severe injury, we have to do Pringle's maneuver, packing, or angioembolism, embolization, and operative repair. Okay, so here we can see total 6 different types of gradings we have for liver. So this liver secondary most common injury, as we discussed before, it may bleed profusely. The management will be like we can do packing, hepatorrhaphy, embolization, and resection. So in grading, first of all, this is the grade 1. The liver got tear here. So we can see hematoma less than 10% and less than 1 centimeters. In grade 2, we can see lacerations like 10 to 15% and 1 to 3 centimeters of the tear. Next we can see grade 3, that is Cournot segment, greater than 50% or greater than 3 centimeters we can see. Next one, grade 4, that is lobe. So in grade 4 we can see that liver lobe will become damaged like 25 to 75 percentage. So that is the lobe will become the injury. Okay, next grade 5 mostly we can see this blood vessels and everything will become injury and everything. So greater than 75 percentage of lobe and major veins will become injury. Next we can see grade 6. In grade 6 we can see hepatic avulsion and are like same. Okay, so in severe injury cases we have to do Pringles maneuver along with that packing, embolization and operative repair. So in liver surgeries Pringles maneuver is very important. What it means? Pringles maneuver means it's like temporary occlusion of portal triad inside the hepatoduodenal ligament. So we can see in Pringles maneuver we can see portal triad. The portal triad, in portal triad we can see hepatic artery, portal vein and common bile duct. So the purpose will be like for controlling hepatic bleeding. So this is the main purpose. Okay, next we can see here that is kidneys. In kidneys we can see hematuria. That is the most common symptom we can see in kidney injury, hematuria, and we have to do CT urography. The most managed conservative, mostly we can manage conservatively. In severe cases we have to do nephrectomy. So total we have 5 grades. Then is grade 1 splenic injury, renal injury, grade 2, grade 3, grade 4, grade 5. Okay, so these are the things. So kidneys is not that much important, that's why I'm not discussing that much. Okay, next we can see here hollow viscous injury repair. So hollow viscous injury also known as bowel injuries. If you're suspecting with seat belt sign, free air, then we have the options. We have some like primary repair or resection and anastomosis. So if like colon injury means it depends on contamination and stability. If options like we can do like we can repair and we can do anastomosis or we can do stoma. Okay, so how to do damage control bowel management means if patient like unstable, then we have to resect injured bowel and we have to staple the ends and we have to leave discontinuity and we have to return later. Okay, so these are the things. So you can see here that the AAST, the grade 5 small bowel injury will look like this. Okay, that grade 5 colon injury will be look like this. The colon will become damaged. Next one you can see AAST grading 2 small bowel injuries. So these are the bowel injuries. Next we can see here pancreas. Pancreas will be like retroperitoneal organ. So the injury will be like very rare cases we can see and it's hard to detect early. So it's whenever if you're doing lab test, if you're checking MLAs, the MLAs level will increase. And we can see high grade injuries may require distal pancreatectomy. Okay, so these are the things. Next we can see some complications. So whenever the doctor asking complications, we have to divide that complications into 2 different types, that early and late complications. In early complications, patient will get bleeding, missed injuries, sepsis, anastomotic leak, abdominal compartment syndrome. This abdominal compartment syndrome is very important. We will discuss later. Abdominal compartment syndrome. Okay, so in early cases we can see bleeding, missed injury and early complications, missed injury and sepsis and anastomotic leak and abdominal compartment syndrome. In late complications we can see adhesions, okay, and incisional hernia and enterocutaneous fistula and chronic pain. In life-threatening cases we can see modes like multiple organ damage, septic shock and massive hemorrhage and acute respiratory distress syndrome. So these are the life-threatening complications. Okay, so next one, abdominal compartment syndrome. What it means? The abdomen have some compartments. So intra-abdominal pressure, if greater than 20 mmHg with organ dysfunction, then you have to suspect patient have abdominal compartment syndrome. The signs will be like distended abdomen, oliguria, hypoxia, and hypotension. So then what we have to do? We have to do treatment like decompressive laparotomy we have to do. So here we can see emergency management. In emergency management, we have to go with advanced traumatic life support approach like airway. In airway, we can say first in airway, whenever you are going to motor like some vehicle accident, if you are going to that field, we have to go with advanced traumatic life support approach. First, we have to check airway. Then after we have to protect cervical spine. Then after breathing, in breathing, we have to check that we have to, if patient have pneumothorax, we have to treat pneumothorax with the needle decompression, or we have to treat with tube insertion. Next one, hemothorax. Okay, next one, circulation. In circulation, we have to control hemorrhage, and we have to give proper fluids and resuscitation, large bore intravenous access. Next, D means disability. We have to check Glasgow Coma Scale assessment. Next one, E means exposure. We have to do complete proper head to toe examination and everything properly. Complete examination we have to do, because secondary survey will comes like head to toe proper examination. So next we can do massive transfusion protocol. If patient getting too much bleeding and massive hemorrhage, then we have to use massive protocol, transfusion protocol. In modern ratio, packed RBC, frozen plasma, okay, frozen plasma and free frozen plasma and platelets we have to give 1:1:1 ratio. Okay, then the main goal why we are giving this ratio and everything, because for preventing coagulopathy, hypothermia and acidosis, that lethal triad. Then after we can do ICU management. In ICU management, always we have to monitor ABG, lactate, urinary output, hemodynamic, patient stable or not, we have to check that things always. Then after we have to give ventilation support. In the main target why we are giving urinary output, the treatment is working or not, how we can check based on urinary output. 0.5 ml per kg per hour, the adult person can excrete urine, so we have to check that thing. Next important thing is mean arterial pressure. We have to maintain 65 mmHg and lactate clearance. Like if it's improving, it's good. Okay, so based on recent guidelines, it's showing like in current trends, non-operative management whenever is safe. Next one, angioembolization for stable bleeding, damage control surgery in unstable patients, and balanced blood transfusion, and LD tranexamic acid is best drug. You can see here most common drugs used in management, that is first one, tranexamic acid. This tranexamic acid this is the best if given within 3 hours of injury. Why? Because 1 gram of intravenous over 10 minutes if we repeat every 8 hours. If you are giving this tranexamic acid, we can stop that bleeding. So that's why. So next, damage control surgery principles. If patient is unstable patient, the phase 1 stop bleeding, control contamination, pack at abdomen. In phase 2, ICU resuscitation. In phase 3, definitive repair once patient got stable. We have to take another time to operation theater. Okay, why? Because we have to control that lethal triad, that hypotension, acidosis and coagulopathy. Okay, so next we can give some broad spectrum antibiotics. Example like piperacillin tazobactam 3.37 grams intravenous every 6 hours if you are suspecting perforation and peritonitis. And analgesics, morphine and fentanyl intravenous. And intravenous fluids like normoxilin, ringer's lactate 1 to 2 bolus initially. Next, blood products like hemorrhagic shock. If you are suspecting hemorrhagic shock, we have to go with 1:1:1 ratio. Packed red blood cells and FFP and platelets as per ratio. So in surgical, most commonly asked Viva questions, the high yield questions I'm going to ask, just recap I'm going to give. Most common organ injured in blunt trauma, that is spleen. Second most common injury will be like liver. The most common hollow viscous injury is small bowel. The gold standard imaging is for abdominal trauma, that is contrast CT scan. If patient is unstable, the most like patient investigation is fast focused assessment sonographic in trauma. And what does FAST stands for? Focused assessment with sonographic in trauma. What does FAST detect? Free fluid. Okay, so most dependent space in males, that is rectovesical pouch. Next, most dependent space in females, that is pouch of Douglas. Positive FAST means Hemoperitoneum until proven otherwise. Otherwise, that is FAST. Okay, so most common cause of death in liver injuries, that is hemorrhage. Where you can see Cahet sign means that is in spleen. Okay, what is OPSI means overwhelming post splenectomy infections. So what are the vaccines after splenectomy the patient have to take, like pneumococcal, meningococcal and Haemophilus influenza. So whenever the patient doing splenectomy, which organ will affect? Tail of pancreas is related to splenic hilum. What it tell me the lethal triad. The lethal triad means hypotension, acidosis and coagulopathy. So these are the questions the doctor can ask you. So most dangerous missed injury, that is bowel injury. Best indicator of perfusion, the lactate clearance. So these are the questions the doctor can ask in ask session. When I did general surgery department, the doctor asked about some questions like he gave one clinical case like 24 years old male motor vehicle collision, a patient present with abdominal pain and hypertension. So my task is I have to do primary survey and we have to do interpret fast and we have to identify shock and we have to do plan management. So the expected diagnosis is blunt abdominal trauma and probable splenic rupture and hemorrhagic shock. So for management, we have to do advanced traumatic life support and fast scan. Then after we have to give proper blood products based on the hemoglobin level. Then after based on patient stability, then hemodynamic stability. Then after emergency laparotomy. Okay. So like this, the doctor can ask in ask setting, he will give one case management we have to do. Okay. So these are the things. So mostly I covered everything in the abdominal trauma part 1, that is like basic about abdominal trauma. In part 2, we discussed everything about management, liver, spleen, pancreas, hollow viscous organ and structures and renal. Okay, and some complications, how to the surgery steps, everything we discussed. So mostly I covered everything. If you have any doubt, you can ask me in comment section. We will meet in our next video with other different topic. So if you didn't subscribe my channel, if these videos are helping you, so like, share and subscribe. So I'm signing off. We will meet in our next video. Till that time, take care. Bye bye. Have a nice